in situations where people report soreness after repeated adjustments. The reason is if the denture is tipping or careening after it first hits one tooth, doesn't matter how much you adjust the inside of the denture, that movement is going to still have the denture hitting the tissue. And that's the source of the soreness. So you have to adjust the occlusion to get it. There are other reasons that generalized soreness may occur. All through the mouth can be a systemic condition, can be nutritional deficiencies, which of course are also systemic, or it can be a low tissue tolerance, which we refer to, but again, these are all systemic conditions. So if it's sore everywhere, you're thinking systemic, maybe you're thinking allergy to the materials. Okay, if people are reporting that they're biting their cheek, usually the reason is for insufficient horizontal overlap on the posterior teeth. So you want to take a look at that. Has anything changed? If it's an older denture, you want to round in the buccal cusps of mandibular molars, or if it's in a crossbite, the buccal cusps of maxillary molars. So you don't want that edge to edge on the buccal. So when you round in, you don't have edge to edge anymore. So the tissues don't get caught, and there's some support for the cheek by the maxillary molars so that the cheek doesn't fall in between the teeth. Remember also to look for, when you have cheek biting, insufficient clearance between denture bases. Remember that the teeth are made of acrylic, the bases are made of acrylic. When you catch your cheek between two pieces of acrylic, it feels the same. Doesn't matter whether it's pink or if it's white. So check everywhere, including the denture bases, for areas where you can catch the cheek. You want about 3 or 4 millimeters of opening between denture bases. Contacting denture bases is not good. Also, you want to look for sharp buccal cusps. This can happen if teeth are worn in a particular way, or if there's a broken tooth. So run the finger over the cusps and round any sharp edges. An unusual complaint, but I have seen it once or twice in my career, is this burning sensation on the upper lip or the side of the nose when the dentures are being worn. So if you get relief when the dentures come out, you know the dentures are likely causing this. And this is caused by the impingement of the nasopalatine nerves exiting from the incisive foramen. So you want to just kind of relieve that area, use PIP to verify before you relieve. You always want to resist the temptation to start grinding on a denture when you're not sure what's going on. So resist that temptation. A lot of times patients will direct you to that, but you don't want to be doing that. First, find the cause before you do the adjustment. With respect to patients reporting a sore throat, and this can happen on an older denture too, gradually after a lot of time, because overextensions can occur as the alveolus begins to resorb. So a denture that didn't have extended flanges may suddenly or gradually start to have overextended flanges as the alveolus that supports the denture begins to resorb. So you're looking at ulcerations anywhere, you know to adjust there. Be sure that you don't have overextension in the hamular notch area. And you want to adjust the distal buccal of the maxillary denture or the distal lingual of the mandibular denture. Those are sources that can be perceived when they're ulcerated or irritated as sore throat. Also, you want to be sure your denture is not on the pterygomandibular raphe, above the retromolar pad. That's not so typical in an older denture, although when the ridge resorbs, the denture may be sliding up that high, and so you want to look for that. With respect to looseness that the patients are looking to correct, again, don't just go right to a reline as a solution. Find out where there's a loss of seal, if a loss of seal is the cause of the looseness. So it's useful to have the patient demonstrate how the denture loosens. Maybe they're going to show you when they open up wide. Maybe they're going to show you when they slide their teeth from side to side. So look at what's causing it, because that's going to give you a hint what needs to be modified. So if the denture is too long, of course, that's going to give you a retention problem. If you put the flange on tissue that moves, then when the tissue moves, that's going to displace the flange. So you're going to mark the denture's posterior border, see if you have the posterior seal in the right spot. You can shorten a denture, and then you can also add to the posterior seal with wax or compound or even bite registration material and test to see if I change the seal, will this make a difference? And if you do make the difference, then you can replace it in acrylic. Okay. So ways to test for a short flange: you can actually look for streaks on the flange that are consistent with the brush stroke, so there's no contact at all with the tissues. That would suggest that it's not touching the tissues at all. That can be overly short. It can look short in the vestibule when you reflect the lip, be it upper or lower. You can see is it reaching to that vestibular area, or is it short of the vestibular area? Sometimes in areas you can't visualize, you can feel. You can run your finger along the tuberosity and the maxillary posterior alveolus and feel whether or not the denture is there or not. If the denture is short in that area, you can feel it with your tongue. Okay, when a flange is too long, you're going to see that PIP burn through. You're also going to hear complaints like, it stays in until I start to speak. So there, that vestibule, of course, is movable as the lips move, as the muscles of the facial expression change as you speak, and that can dislodge. So watch also when seating the denture, when the flange touches the vestibule, does it continue to seat and push in the vestibule? Does it stop right at the vestibule as you seat it? So those are things that you can evaluate clinically. And when sometimes if there is a resorption of the alveolus, well, of course, the palate doesn't resorb, and so the palate remains the same, but there's two sides of the denture. Then you'll have some rocking that can often be from the hard